Good morning, everyone. So, it's really a very great, I suppose, movement which has happened where pulmonologists and cardiologists are talking to each other. We started our journeys, I think there are a couple of people who are as old as me, including Randeep. We are talking to cardiologists was almost like impossible. You send them, they do angiography and send them back. And that's all. That's the only interaction we used to have. And this disease required for them to step out of their comfort zone to perform the right heart catheterizations and then even to call for the MDT to discuss that. That was the worst part of it, actually. I think had our Samir not come from US, I wouldn't have got a cardiologist to convince to come for the MDT to discuss the PH cases. And it is really, I'm telling you, it's a movement forward. But what has propelled this movement? That is the pharmacotherapy. If you have a drug to treat, then you want to actually really go down up to the diagnosis, that what is the right diagnosis, and you don't want to choose the wrong drug or give a wrong drug. And there are so many things which are still, I suppose, not very clear. And I think even the last case has left with much more questions in the mind than the answers. And mine one will also do the same. So please forgive for that. And this is, of course, I forgot that I was supposed to discuss the management because I just thought it's a group 1 PH. So whichever patient came in the last 10 days, we just picked up that case. And it has not yet gone into our own MDT yet, let me admit that. So I'm going to talk about this group 1 patient. So this is the group 1. And I think, leave him aside, I think he's a cardiologist friend. Is that right? Yes, sir. Oh, great. So the pulmonologist, which is the most common ones you see out of them? And if people in the hall say none, I will accept that. Absolutely. How frequently we see idiopathic as a pulmonologist?
I would say the CTD-related pulmonary hypertension.
Absolutely correct. That's our domain, where we really get to see them much more often, and that's where we are basically. And of course, sometimes we might get across patients of portopulmonary hypertension. Sometimes we might get patients who have got liver disease who are undergoing TIPS or transplants where they come up to us basically, and they have a lung disease also. I haven't seen drugs and toxins, and heritable is yes, but like he said that he sees almost like, you said about 10 to 12 per year, like 1 case a month of idiopathic heritables.
Heritable, no, I mean, heritable are rare. So out
very
of,
rare.
Yeah. In a year, maybe okay. 3-4 out
3,
of.
4.
Yeah.
So 3-4 is a very good number because if I get 1 case, I'm going to publish it actually. And we have got only 1 case so far. Only 1 case so far. But yes, it depends upon how aggressively you investigate and whether you are a PH center or not, where they will come and spend that much of money to get complete investigations done. So for us, even to get a right heart catheterization is an issue. It is an issue because if they really cardiologists charge for right heart catheterization, they end up getting nothing. Really, they get nothing because the scorecards of right heart catheterization is, I think, 12,000 rupees. So much of trouble and 12,000 rupees, and I think so much of mind games just for 12,000 rupees. So it's very, very difficult. So if you people who are all sitting here, who are seeing PH and are feeling frustrated that you're not getting right heart catheterization, it is nothing new. It is definitely something which is an acceptable fact. All you need to do is allies with somebody who's really interested in this work and would be more than happy to assist you. Like a guy sitting here with me, the cardiologist, right? So my journey was in 2009 for PH, and that was primarily because sildenafil was to be tried. There was trials, and they wanted right heart catheterization in all of them at the baseline and at 3 months. You can imagine how much of we created a problem in the entire hospital that we need 2 caths to be done for the patient, for the trial. And, but the good thing was they were getting sildenafil because it was not a blinded trial. So it was for group 1, but we were allowed to recruit the patients of connective tissue disorder related when it fits into the criteria which they wanted, where lungs are not bad, lung functions are not so bad, and it's primarily the pressures there. So that's what we see most commonly. So this is 33 years female. She's a non-smoker, performs a desk job, and she has a dyspnea on exertion, grade 2 to 3, which has increased in 4 months, and she is already diagnosed as a mixed connective tissue disorder, and she is on oral corticosteroids 10 milligram per day and MMF 2 gram per day. She had only GERD, and she had no other significant symptoms to suggest anything related to pulmonary artery disease like syncope or palpitations or things like that. And in autoimmune symptoms, yes, she had dryness of mouth, Raynaud's was there, mouth opening was normal, no dry eyes, and she had a room air saturation of 94%. See, 33 years, 94%, 82 is the pulse. There was no clubbing, neck veins were not engorged, there was no edema. Chest was okay. The cardiovascular system was not very significantly abnormal, let me admit. Even my postgraduates do not know when S2 is loud. It is very, very difficult to teach these days. I hope the digital scopes will help us a lot to actually, do a good cardiovascular examination. FEV1 was, so they had lung functions, FVC 64% and FEV1 63%. And you can see the autoimmune profile, which shows ANA positivity, and in the ENA, there was SSA rho was positive. So she was being under the treatment of rheumatologist as a case of mixed connective tissue, where there's an overlap with SCC as well as Sjogren's syndrome. To some extent, that was the diagnosis, and the treatment was going on. So the next question which comes to mind is that should we screen the patients who are into this group 1 PH? And from a pulmonologist perspective, you will have a couple of conditions in which you can. So, comments from the panelists. Radhika?
So there is a role for screening in group 1 PH, especially the CTD. So you would want to look for any CTD features, especially if you've got a young female who comes in with unexplained dyspnea and you see pulmonary hypertension. You would also want to screen for HIV. You would also want to look for sarcoidosis, because that's associated with type 1. And of course, genetic testing, if that is available, so the BMPR2 gene that you would think of. So these are the few things that I think could be looked for.
So
screening.
I think you brought it very well, that you really need to do this, because the group 1 PH is the one which is rare, we understand. But more important than that is, normally there is a very significant delay in diagnosis, roughly about 2 years. And of course, the major thing is that despite all we are talking about here, there's no change in the last 2 decades as far as the mortality rates of this condition is concerned. And of course, there are confounding medical conditions which confuse the picture completely. And symptoms are so non-specific that it is very difficult to do it. And very importantly, when we talk about CTD, if you pick up the group 1 PH in CTD, 30% will die in 1 year time. So that is the importance, that you should screen them, because the mortality rates are very high, and chances of missing them in a daily practice is again going to be a very difficult one. So you can't see this from here, right? Okay, it's okay, fine. I absolutely right. Even I'm finding it difficult to see from this side. Okay, so that's the basic thing, that why we should screen. But the important thing which will come to is that there are certain recommendations for particular conditions which should be the ones where you need to screen them. And scleroderma, mixed connective tissue disorder, SSC overlaps like the one we had here, first degree relatives of hereditable pulmonary hypertension, which Dr. Tala spoke about it. And Radhika said HIV, yes. Chronic liver diseases patients, yes. Patients going for liver transplant, yes. And there is a very doubtful role when it comes to patients, what we see in daily practice, that is chronic respiratory diseases and patients with obesity, hypoventilation syndrome. So that's why they are a question mark. But other 6 boxes are where it is more or less in the process where we should start thinking that they are high-risk individuals. We should actually do the screening. Of course, the question comes that when and how to suspect PH. Ashish?
Thanks, sir. Any patient who is coming into our OPD, if he is suffering from progressive dyspnea,
Correct.
if that dyspnea is not being explained out of any obvious region, like COPD, ILD, even if it is explained, but that dyspnea, if it is progressively increasing, obviously we are going to suspect over this pulmonary hypertension whether he is developing or not.
Okay.
So therefore, we always keep in mind whether we have to investigate further and to get this pulmonary hypertension ruled out.
Correct. So you spoke about the clinical indicators to suspect pulmonary hypertension, and they are very important because worsening dyspnea, dizziness spells, syncope, palpitations, tachycardia, parasternal heave, loud P2, JVP raised, and peripheral edema are some of the features. But I suppose the classical clinical signs start coming in when the disease is clearly overt. What you have initially is, very rightly Ashish said, worsening dyspnea, which cannot be explained. I think that was what even Madhukar's case also brought in very well. But how many cases of worsening dyspnea you see every day in your clinic? I think every patient who comes to me with a worsening dyspnea. I can't start suspecting in every patient because the screening should be followed by a screening test. And that test is something which is, I'm going to talk about with a cardiologist colleague here, that how difficult it is to get a good one done. It seems Mumbai is very lucky to have him who spends his own time. Our place, the echos are all done by technicians. All are done by technicians. I don't think so. And sooner or later, I think there will be all probes which will be given into the hands of some trained people who just know where to keep the probe. That's how it's going to happen. Then comes the lung function. So I think you can make a comment, Sumit.
So whenever there is a disproportionate fall
So
in the
they discussed
DLCO,
that in 6-minute walk test, there is excessive desaturations happening, right?
Yeah.
Yeah.
And the other thing, I mean, even looking at the history of this patient, she doesn't have any airway directed symptoms. She just has dyspnea.
Correct.
So for us to suspect that she has a major interstitial lung disease, because there is no cough, there is no dry cough or anything. This is just progressive shortness of breath. That is another indicator that there is another mechanism which is driving the breathlessness. And here, obviously, the DLCO is reduced to less than 40%. The patient is already hypoxic at 33 years of age with no environmental exposures. So, and of course, the 6-minute walk test going down would suggest that echo is the next thing to do. And
So
of course,
basic tests which are available to us can give indications, which like in Madhukar's case also gave an indication. The indications may not be so clear in most of the cases. That's the challenge. So that classical ratio of FVC over DLCO percentage coming to 1.6, 1.8, 2, people keep on increasing it to make it more sensitive, more specific, but obviously then it becomes less sensitive also. So 1.6, which is a one used, in sarcoid we use 1.8, but this is just a rough figure which people have proposed, but it's not a very sensitive and a specific measure. But yes, it should change your thinking process towards that I need to look into the pH at this moment of time. But the most important test here is a cardiopulmonary exercise test. CPAT. How many of you in Mumbai here who are sitting here are performing CPAT? No, I asked for Mumbai because I know you are doing it. I know Randeep is doing it. I know I am doing it. So I am not saying that. I'm saying anybody in Mumbai. So in Calcutta, are you doing it? Nowhere. So he's obviously okay. Great, 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 great. CPAT is definitely one of the very good tests. Because what is the resting hemodynamics? They are going to be changing completely on an exercise, and this is an exercise which is a maximal exercise test. It's not a 6-minute walk test. अपने आप घूम लो धीरे धीरे कोई बात नहीं बीच में रुक भी जाना तो भी allowed है सब कुछ. No, this test is made to suffer the patient, where the patient has to see I can't do more exercise. So what is failing you? Is it your lungs are failing you? Is it your heart which is failing you? Is it your legs which are failing you? Or it is your anxiety which is failing you? They don't collapse. They never ever collapse. We have never ever seen in last 20 years of CPAT any patient collapsing in the CPAT lab. It's never happened. Yes, in a way we screen them well for a cardiac because we have a very close association with cardiologists. Can't work without that. That's why Metro Heart Institute comes first, respiratory comes later. I accept that because I get a good help from them, no problem. And then, of course, we discussed about the biomarkers. So, Ashish, so do we do routinely the biomarkers in these patients, which is very simple now, NT-proBNP. But I learned that in Patna, when you do an NT-proBNP, it takes about 1 week for the result to come.
Actually, sir.
Prakash is sitting there, I know. How much time it took?
Sir, no, these biomarkers are.
Chalo, बहुत अच्छी बात है फिर तो. Then very good. So everybody is ordering left and right NT-proBNP, right? Huh? Not left. In a dyspnea of unknown origin, NT-proBNP is the test which is to be performed. D-dimer and NT-proBNP are the two tests which needs to be done if somebody comes with dyspnea of unknown origin. And especially if the lung functions are not bad, then of course I'm looking at everything else in this patient. And a simple biomarker is there. So suspicion is intertwined between clinical, the physiological, as well as the biomarkers. And luckily we have a biomarker hit here, correct. So I think, yes. Now, lung functions we have already discussed actually. Did I go back? What happened? No. Yeah, CT scan, okay. So obviously everybody wants to think that it is ILD which is related to this thing. Why is it not working? Okay. Sometimes computers are more confusing than us. So, you know, when you project that, like Dr. Modi said, that it was looking like a PVOD. So lots of things looks like PVOD because when you don't see many things clearly on a CT scan, you start looking for PVOD because that's one place where you don't want to go wrong. And since PVOD is also group 1, so there's any radiologist in the gathering? There's no radiologist. So somebody who knows radiology very well as a pulmonologist, any volunteer? Any volunteer? In fact, I have 2 chairs vacant here. So can 2 people come and sit here? Sujit, why don't you come here? Why don't you come here? We have two things out here. Somebody should volunteer. What's the problem? Come. It doesn't look nice. There are 2 chairs there. It doesn't look nice. Yes, this is what the spirit is. And I'll get Randeep also on the stage. I take liberty of always putting Randeep into difficulties. And he never says no. He never says no. That's the kind of spirit we should all have. Because this specialty requires, this disease specific area requires a lot of discussions with our colleagues as well as among ourselves. So, do you want me to play the CT again, Sujit?
Yeah, please.
Okay.
So I'd gone to grab a coffee because I realized there's no coffee break. So and that's why I missed the history. But the scan, from what I can see, I saw a small patch of honeycombing at the base, and otherwise a largely
Some esophageal issues are there.
Yeah, there's a little bit of.
There are esophageal issues, and very rightly, as you
Yeah.
put it, that there was a patch of honeycombing there.
The
I
left
think
base has a little bit
it's
of
on the left
honeycomb.
base, right, Randeep?
yeah.
Yeah, left
The
base,
left
and there
base.
is a little bit of dilated esophagus, maybe
Yeah.
a little bit of hiatus hernia.
Yeah.
Hiatus hernia. So actually, the SSC Sjogren overlap is correct, and we are looking at lungs which are not that bad.
How old is she?
Sorry.
33.
Lung volumes are not reduced, and honeycombing is at the moment localized to the left side. So whatever are the consequences which are coming, they don't seem to be correlating with the CT scan finding. Is that right? Any comment?
So they seem to be out of proportion to the CT scan finding.
I think that's the best word. Out of proportion to the CT scan findings, out of proportion to the lung functions, out of proportion to the clinical findings. Everything is out of proportion. Radhika, you want to say something?
So there's no overt ILD.
Sorry?
There's no overt ILD here.
There is no
overt ILD that we're seeing.
clearly the one which comes and slaps on your face that I am ILD is not like that. It is like very, very subtle, which a very expert radiologist like Sujit Rajan can pick it up. He's the radiologist among us.
So hemoglobin is normal.
Sorry?
Hemoglobin is normal.
Hemoglobin is, yes, normal. It is 13.2, something like that. Yes. The organizers should not ask questions. Let others ask questions. Otherwise, there would be no time for others to ask questions. In fact, I will invite people from there to make their comments. This is the kind of case which you see every day in your practice. And I'm telling you, I have also seen it only in the last 1 week, 10 days only. And I am supposed to discuss the therapeutics. Good that I'll get an idea as to how to treat this patient. Thank you very much for that also. Yeah, so this CT scan does not explain that what is going on to these patients. Okay. So what are the other tools? When we talk about the tools, these are not the good tools. Look at the chest X-ray. You have this classical teachings going on. And it is said that it is 90% times abnormal in the patients. In this chest X-ray of the patient, we could hardly get anything. And this classical CT scan on CTPA, and there is one sign out shown here with a arrow. Can anybody name that sign? Anybody here? Anybody? Name that sign. You know, there's an arrow out there, the orange colored arrow. It is trying to show you something, which is telling you that there is something to suggest what the disease which we are talking about. Anything? Anybody know? I'll be ashamed if there are no postgraduates. Otherwise, they would have really got the best out of it. It is called bikini sign. Now you re-look at it. It looks like a bikini. So that's why it's called a bikini sign. There's a triangle. You can see that triangle. There is aorta and a pulmonary artery on both sides, and there is a mediastinal fat in between. That's what is called bikini sign. Anyways, and of course the lung nodules and other things which everybody said are the other things to look for, but very limited sensitivity. Anyways, I think everybody wanted to see the mediastinal window also. So let's see the mediastinal window. We didn't do CTPA. So we can ask our cardiologist colleague to help us.
Right, so right off the bat, the pulmonary artery is severely dilated, and I think there was enlargement of the right ventricle as well. Ooh, okay.
Not very significant.
Yeah. No, yeah.
Not
the right
very
ventricle
significant.
is actually
Yeah.
not very dilated. It's the
yes.
pulmonary artery which is significant.
Pulmonary artery is a megapulmonary artery.
Yeah.
Correct. Okay. So how many of you use CT scan to, think that it is probably a pH and start working on that. Any comments? Yeah, yeah. Bhattacharya, how much you can rely on a CT scan?
I rely quite a lot on it.
Quite a lot. We all do that because we can get CT scan at the drop of hat. What's the problem?
You can actually see the chambers pretty clearly, even if it's a HRCT without dye. You can make out the right atrium enlarged, you can make out the left atrium enlarged. Sometimes you can see impression of the septum, you can find the D sign, just looking at the cardiac shadow.
So
And if
you,
look at the
you do
pulmonary-
a contrast CT for that, right?
Not at all. No, no, no.
In the
Just
plane.
plain
Okay.
in mediastinal
So
vein.
again, I will admit this, that our radiologists do not ask for contrast CTs at all. Nothing. Only plain CT scan, and they say they can give as good information without giving extra dose of contrast to the patients and troubling their kidneys. So no problem. No contrast. I do not know why we are still churning out contrast CT scans in the small labs, but it is really not required in any patient. But everybody says it is very, very reliable. But I have written it here, but that CT does not provide you the pressures. It's only an anatomy. A dilated pulmonary artery can be an idiopathic dilatation of pulmonary artery. We reported that there was an artery which was like 37 millimeter in size. We did a right heart cath and the pressures were normal. Idiopathic dilatation of the pulmonary artery. So like the size matters, but does not reflect the pressures. That's an important thing. And of course, normal PA cannot eliminate pulmonary hypertension. So even if you don't get anything in the size, okay, forget it. Most commonly, we use a pulmonary artery and aorta diameter ratio, and that changes with the body size. That depends upon what is your body weight, what is your BMI. And of course, dilated PA can be there when there is a pulmonary fibrosis because of the pull. The fibrosis is trying to pull the pulmonary arteries. So in those ILD patients, you can have a pulmonary artery dilated. And of course, when you really need to do a pulmonary artery pressure estimations on the CT scan, then you need a multidimensional views to do that actually. You won't be able to do this. And of course, they are there because once the CT is done, it is there. But only thing is the radiologist also need time to do all those kind of measurements, which is generally not done. So it's not the one. So then is the echocardiography. I think echocardiography, this is the best I could get hold from our friends. Forget about what is reading this. Just look at this. I'll admit that I do not know how to read the echocardiography. I'll admit.
Okay, so it's just the same loops. So
Yeah.
grossly, the right ventricular size looks okay. Grossly, the left atrial size, at least what's seen over here, looks okay. The TR jet signal is very poor,
Very
so the
poor.
estimated
Exactly.
PA pressures are not going to be very reliable.
Exactly.
If we could get the right ventricular outflow tract, any other information? No. Okay, so
I think
actually
that's
this
the crux of it.
this echo
This kind of echo will deter you from taking any decisions actually.
If
That
I-
is where we really need to understand that what is the pitfalls of an echocardiography. We all look for TR jet velocity. We are talking about calculating systolic pressures, but it is very misleading with inadequate regurgent jet. So if the jet is not there, then whatever you are going to give is of going to be no use at all actually. That's a very problematic thing. Now, the echo sensitivity and specificity which I have written, it is a cumulative one which has been reported from the literature, and that's what I have given you. More than 80% sensitivity and 40 to 80% specificity. That itself tells you 40 to 80, such a big range. What does it mean? It's definitely a handling person dependent. And what's your experience then? I will ask you about echo. No, yours will going to be super. We all are troubled by this, I suppose.
Sir.
Is that right? Yeah, Ashish.
Yeah, actually, sir, in our clinical setting, whenever a patient is coming in our OPD and we are suspecting pulmonary hypertension, this is the first, in fact, you can say investigation which we do. Actually, why? Because
So my question is
yes.
that are the cardiologists doing or the technicians doing? Number one. Number two,
Yes, sir.
how communicative we are to our cardiologist for every case of a PH. So in Bombay, I think the practice is different.
No, no.
So I would say that it is not in our hand, like where the patient is getting the echo from.
Okay.
Same as in interstitial lung disease. If you have a good HRCT, you'll get a better diagnosis. So when the patient comes to any hospitals here, where the echo was the echo done in a bigger hospital? Was it in a private setting? Was it done by a technician?
Even bigger hospital doesn't mean that it is done well.
Not necessarily, but then you have an opportunity to talk to your colleague,
Correct.
which is not there when the patient comes from outside. And specifically what I tend to do, if I'm looking for pulmonary hypertension, I would specifically mention in the echo request that I'm looking for the right heart reading.
That's what
specifically.
Sujit also does. So this seems to be a Bombay practice, Radhika, that you talk to this person. So Partha wants to make a comment.
I'm
Partha.
very lucky because one of my good friend is doing echo at my institute itself.
Oh, you
And
are
we look
extremely
for
lucky.
Almost all possible parameters.
I can understand. He is a very rich man. He can employ a
He's a
cardiologist
very
in his
poor
own
man, only
clinic.
grassroots physician.
He's a very, very rich
For the
man.
compliment.
Nobody can afford a cardiologist in this gathering. I'm pretty sure. Ask him. So
affording
I
is-
agree with you. Sujit, tell me one thing. How many times the cardiologist, once they are contacted, they will say, okay, send the patient back again, we will do it again, we will spend more time with the patient and then give you the report.
Yes, this used to happen about
This
a
is
few
still
years
happening
ago.
every day
Yeah.
with us.
It doesn't happen now because now the senior cardiologist has designated one of the younger
Okay,
cardiologists
I think
to
very
do the
good
right heart
message
echo.
that
Yeah.
if you are constantly pushing this, then
Yeah.
you don't have to for each case do it.
Correct.
But you need to have a liaison where you are actually going to that person again and again. Because there may be 10 cardiologists, like Randeep, you must be having 10 cardiologists in Medanta.
Right.
So you must be also focusing on one that this guy does good. Is that right?
In fact, before Randeep speaks, I'd add that in most pulmonary vascular centers, and Tala may testify to this, the chest physicians who are doing the echo. So they're actually getting trained in echo. And if chest physicians can get trained in ultrasound, I don't see a time in the future where they will not. I mean, I know maybe I'm treading on a
Nobody will.
tricky
No,
area.
cardiologist will not allow that at all.
Let's see what Randeep.
Cardiologist will never allow us to do that.
So two things. One is you have to liaison with a good cardiologist who will listen to you and who's able to do it. But I would really take Sujit's comment forward. I think that is something that we need to look at in the future. Many years ago, we used to do as part of Pulmonary a workshop, and we did one 4-day workshop
On echo.
ultrasound in critical care, where echo became a major issue, and this was done by the American College of Chest Physicians, where all of them do their own echo as far as cardiology, as far as pulmonology is concerned.
Moving forward.
And we had a huge argument with the cardiologists because they were not happy that we were actually doing a workshop on training pulmonologists how to do an echocardiography. But if you are working in critical care and you have a patient who's sick in the night, it's very important to be able to have some idea of echocardiography.
I perfectly will
I'll
understand.
give you an example also. I had one patient whom we transferred from another hospital, and she had delivered a few weeks ago, and she had sudden onset shortness of breath. She was referred as pulmonary thromboembolism, and she came late in the night. The resident did the echo on the bedside in the ICU and said this looks more like global hypokinesia. And she had actually postpartum cardiomyopathy.
Postpartum cardiomyopathy.
She didn't have pulmonary
Correct.
thromboembolism.
I think
and he diagnosed it because the fact that if you start training your residents,
yes, I
at
think
least the baseline echo they will be able to understand.
opening up of minds is required, and obviously I think initial inertia is there. If a cardiologist in his clinic starts doing lung functions, you feel very bad actually. उसने spirometry भी लगा लिया, अब और क्या करेगा वो? So this has happened in Delhi. Let me tell you, the biggest
so let me ask you one
echocardiograpist. No. Let me tell you, the biggest echocardiograpist of Delhi in his clinic, he does the echocardiography, he does the lung functions also with that.
So let me ask you one thing. How many of you do ultrasound? Basically as an ultrasound for your lungs, whether it be for pleural effusion, pneumothorax, looking for lung slide, for B lines, or even for DVT. So if you're doing an ultrasound, you just have to change the probe and you can actually do an echocardiography. And if you just take a little bit of more interest, you can do it. And I'll tell you again, when we started doing ultrasounds, and I used to work in medicine then, we used to do kidney biopsy with ultrasound guided kidney biopsies. and of course pleural taps. The radiologist got upset. Why did the medicine department buy an ultrasound machine? But you had to do ultrasound guided procedures, and when you move forward, you have to start doing more and more guided procedures because they're more safe for your patients.
Correct.
So I think we are moving out of our silos,
Yeah.
and the
I
time
think
has
there's
come that we
one
really
question.
need to understand that.
There's one question here, yeah. Or comment. Welcome. Wow, great.
Mike.
Do we have a mic to give it to him? Yeah.
I've been doing echo since 1975.
Oh God.
And I've learnt echo from different people. I'm in Bombay. I've done echo with A mode, B mode, M mode, two-dimensional, all types of Doppler, and so on. Now, I must tell you one thing. Your comment that whether it is done by technician or a cardiologist, it does not matter who does it, but the one who knows it, and one who has a good machine, and one who is dedicated, his reports are reliable.
Okay, so
That
I
is
think
one thing.
AI will help us in future here.
Absolutely,
seems.
it will
Yeah.
help because most of the
I think that'll be good.
many
Yeah.
places nurses are doing echo,
Yeah.
and actually
Correct.
many people used to come to me.
I think very welcoming comment, that
Okay.
we should move towards that, and that is a very welcome comment, I would say that.
And it's not a monopoly of a cardiologist or anyone.
Okay.
You have to, each one has to learn sonography pertaining to their own specialty. And
Okay.
That's-
And I think,
that's my comment.
Deepak, I don't think pulmonologist Deepak would be unhappy if cardiologists started doing lung function. I would hope for that day.
No,
to come.
I'm not talking of today. Today, I'm talking of year 2000. Okay. I'm talking about 2000. I'm very old, Sujit. You forget always that. I finished my graduation, post-graduation, everything in 90s only. Millennial से भी पहले वाले हैं हम. बहुत पुराने हो चुके. Anyways, I think the crux comes here. If the diagnosis of a disease is done by right heart catheterization, how many of you are sending patients for right heart cath and getting it done? Getting it done. Sending to ho sakta hai, getting it done. Raise your hands. That's precisely the reason why this symposium is being held today. I think that's the precise reason why we are all gathered today, that ECO is not the diagnostic tool. ECO is a screening tool. If you really need to treat them, you need to have a right heart cath, because I think the classical case which Madhukar showed, that the patient didn't do well, I still feel that it was not lung, it was definitely a cardiac one which was missed somehow, or maybe becoming complicated later on, and then didn't do the way it should have done actually. So, there are so many things. And if you have not done even right heart cath, then I think you are in a blind sea. You are absolutely in a blind sea. So which patients you send them for the right heart cath? That's the question. Anybody? So somebody sends from here.
So one is basically disproportionate echo
Out of proportion.
pulmonary artery pressures.
Suspecting group 1.
When you want to check whether the wedge pressure is up, as I was saying in the first, when I introduced this symposium this morning, Deepak, I don't think you had come in that time, left ventricular disease, diastolic dysfunction causing pulmonary artery
Absolutely.
pressure.
Yeah.
Pre-transplant, they definitely need it. And when you're suspecting pre-capillary pulmonary arterial hypertension, I think a baseline connective tissue disease, a baseline is good. My cardiologist is a senior cardiologist whom I work with at my hospital. He doesn't agree all the time when I ask for it. Sometimes it's not about the monetary aspect. It's just that he says, Sujit, I think we can do without one. And I think that's one of the reasons for the symposium. When should we actually have it? When can we do without one?
Right. As usual, very articulate answer, Does not agree means he doesn't listen to me, basically. It's okay. I understand. So you send patients to right heart cath, especially when you think that the therapeutics is going to change the scene there. So how many of you, if you have a drug to treat the group 3 pulmonary hypertension drug available, will go for a right heart cath? At least little more now, little more. I suspect that if the drug is going to be very expensive, then it will be done. If it is very cheap, it will be better not to do it, just give the drug. Isn't it? Any comment, Randeep?
Possibly, yeah.
Possibly, correct. So actually we need to change our mind, because in the end they become complex cases where there is not one particular reason for that deterioration of the patient. There could be many, and some of them could be still correctable. Is that right? Now I need your comment.
Absolutely, sir. So before we go into right heart catheterization, for this patient, given the resting, what a mild hypoxemia, did we do a
94 only.
lung VQ scan?
Yeah, we did the VQ scan actually. I couldn't put it, but we did VQ scan. That's why we didn't do CTPA.
Right. So right heart catheterization in PH, if you look at what the guidelines say, as Dr. Rajan sir said, they would probably emphasize doing one at baseline before initiating therapy for everyone. But I don't think we can copy paste the Western guidelines to our Indian pragmatic clinical practice. There are specific scenarios in a practical situation where I do right heart catheterizations. And one of them is obviously when you have unclear diagnosis. Number two is to rule out certain other risk factors. There might be risk factors present but not really contributing to the phenotype of PH. So to rule out those, as Dr. Rajan said, rule out left heart disease as a significant component. Number three is when you have an unexpected change in your clinical trajectory. Say if you have ILD and suddenly the O2 requirements have increased and now the patient has RV failure symptoms, pedal edema, syncope and whatnot. Absolutely at that point. And the last but not the least is before you think about transplant evaluation. And it's not only lungs and heart. We have a very busy liver transplant program. Every month I see at least 1 or 2 cases of portopulmonary PH.
Very
and this portopulmonary PH really impacts their prognosis, impacts their listing on the wait list, morbidity, mortality, and how soon they should get a transplant. So before those, and also before we do something more invasive like pot shunt. So
you definitely need to do. So that's why we said tips and transplant, you need it.
Absolutely.
I need your comment on this, because after all this 7th symposium, they came down to this conclusion that if the clinical suspicion is high, then irrespective of echo findings, the cath has to be done. And if it is low, then intermediate and high suspicion raised on an echo would help you to push the patients to PH. You agree with that?
Sir, again, if in the first line here, the clinical suspicion being high, and if the patient, I would definitely start therapy. I wouldn't wait to start therapy. If the
dual therapy?
Yes.
Or triple?
So if the clinical suspicion is high for PH in this patient, say this patient, 33-year-old,
okay,
with mixed connective tissue disorders, echo showing pulmonary hypertension, which is more than moderate, preserve RV function, NT-proBNP is high, I would start dual upfront therapy.
Okay.
And if the patient does not improve, or if the patient worsens in the next 4 to 6 weeks, right heart catheterization.
Okay, I would have expected you to answer it the other way around, that if the patient agrees for right heart cath, I will do it, otherwise I'll start upfront therapy.
No, so
but
again,
anyways,
sir,
I think what you are saying is the practice.
I
This
think
is the
that's what
practice.
I do in my practice.
Everybody does this practice. Yeah. But I think this is exactly what I was saying, that the guidelines now say that follow this, but anyways, that's okay. So this is the right heart cath of the patient. So these tracings are not this tracing. This is our format of reporting it only.
Good. So I'm assuming you want me to say something. Sorry,
no,
sir.
obviously. Yeah.
I took the
entire set on the other side is sitting to listen to you actually. What you want to say?
All right. So
I have come to this side. I'm the listener now.
So definitely, if you just look at the RA pressures, they are normal. The RV systolic pressures are high. How do you know that this right heart cath was done properly? I look for a few clues. Your RV end diastolic pressures, 66/3. The end diastolic pressure should approximate the mean RA pressure. If it's not, then you know that there is something wrong. Kuch to gadbad hai, this is not right. Then you go on to the PA pressure. This is okay. The RV EDP is 3 and the mean.
I'm going to go and talk to my cardiologist.
The mean.
Somebody has taught him
the mean RA pressures are approximate the RV EDP. Then you go on to the PA pressures. The PA systolic and RV systolic pressure should be similar unless you have pulmonic stenosis. So this is in that range, which is acceptable. It's quite strange as to why the PA diastolic pressure is 3. Now that's something that raises a question about the accuracy of the right heart catheterization. PA diastolic pressures and the pulmonary capillary wedge pressure. Your pulmonary capillary wedge pressure can never be more than the PA diastolic pressure. Flow jayega hi nahi aage. It's not physiological for the pulmonary capillary wedge pressure to be more than the PA diastolic pressure. So probably यहाँ पर extra dip, वो false dip हुआ है, and maybe they took into account whatever the computer was showing and not really looked at the waveforms. So that is not correct. But severe pulmonary hypertension, let's assume that the mean PA pressure is it's high, it's above 40, and the pulmonary capillary wedge pressure is low. So that put together will tell you that the transpulmonary gradient is high. So 40 minus 8 is 32, and cardiac output and PR. And someone has also taken the trouble of doing a shunt run to rule out any intracardiac shunts. So that tells us there is no intracardiac shunt. This is precapillary pulmonary hypertension with preserved cardiac output and a high PVR.
And a very high PVR, right? So this is exactly what the MDT does it. Yeah, sure. Go back? Okay. So this is a reading here. All the readings are here actually. This is how actually, oh.
So if you look at here in PA, the diastole looks, as per the graph, it is high only.
This graph is not this graph at all. This is not a patient's graph. I said right in the beginning, this is a reporting format just to teach the postgraduates, and then they just do not know what to do with this pressure. So that comes here, the table, to explain them that put whatever is wrong and then try to come to what and where you are going for. So, Dr. Tala?
Tala, what would happen to the pressures if this was pulmonary valve stenosis you were mentioning?
So there will be a gradient between the RV and the PA pressures. Generally, a peak-to-peak gradient of more than, say, 20 to 30 is significant. Mild gradients of 5 to 10, I wouldn't even consider. Yeah. So
there may be some mistakes here. I will be able to rectify it.
So as we said, the RA pressures are okay. The PA pressures are significantly elevated. The pulmonary capillary pressures are low, normal, and the cardiac output is fairly well preserved. The TPG and the pulmonary vascular resistance are significantly elevated.
Right. So the conclusion is precapillary pulmonary hypertension.
Absolutely.
All right. So the last question is how to treat it. I'll leave it open. So he has already said n number of times today that dual anti-PH therapy is the guideline now, that you start both of them. Now, what is the trouble? The trouble I could sense in his patient when they are hemodynamically unstable. They may actually stabilize dramatically by starting a dual therapy, he is correct. But in some patients, it will actually cause immediate deterioration if we had not done right heart cath and we are not sure what we are looking at. But in your case, we were sure of. That's why I was saying that, you know, without right heart cath, if you would have just given sildenafil or tadalafil to the patient and the patient deteriorates, what will you do? Stop it, finish, that's all. Next 6 months, patient will be gone. So do it when it is possible, not otherwise. And yes, even patients on oxygen, like 4 liters, on aggressive therapy, they have become room air normal saturations.
So pulmonary vasoreactivity testing?
No, they didn't do it on that. I do not know. They didn't do it actually.
That's an important component.
Yes, for that lifetime responders.
Correct.
That's
so
another group in the group 1, which is like
exactly.
you can treat them with calcium channel blockers.
And it remarkably improves their prognosis.
Correct.
It's rare, about 10% are vasoreactive, but if they are, it remarkably improves their prognosis.
So what do you tell your cardiologists? Do the vasoreactivity test when you do the right heart cath, right? Yes. Especially if you're suspecting.
So you send them for a right heart catheterization with pulmonary vasoreactivity.
So if we suspect
test.
group 1.
Which drug do they use for this vasoreactivity?
So I
Adenosine?
purely use inhaled nitric oxide.
Oh.
Okay.
Adenosine?
We
Adenosine
can use adenosine, but sometimes when the RV is sick, it's very scary. I don't know if you've seen how, obviously Guleria sir is well versed. When you give adenosine and if the RV is bad, you can have a prolonged duration or at least 10 seconds of a flat line or an arterial line. It's
That's
very scary. So it's very short acting. So nitric oxide is safe. Inhaled nitric oxide is safe.
But for that, you will require a nitric oxide. in
Yes,
the
you
cath
need
lab.
to have a nitric oxide delivery
Most
system.
cardiologists who do cath know the dose and all that, or we have to tell them?
No, it's a fixed dose, sir. There is no titration.
Okay.
It's a fixed dose. If they know how to do a right heart cath for PH, it's a fixed protocol. It's
So-
fixed dose, 20 parts per million for 10 minutes. That's it.
I tell you, Sujit,
Okay.
that till the time we got the cardiologist who's doing right heart cath, previous they were doing nothing actually. They had no idea and they had absolutely no. So really you need to,
Prompt them something.
from the person who's doing it, who knows the protocols, I think that's the best thing to do it, because a routine people are cardiologists who are doing angiographies for the left heart. They are not very well versed with that. So which two drugs to start with? And I will ask one more question. We are a pulmonologist. We are not big-hearted people like our dear friend. We are chicken-hearted people. So sometimes, you know, we start with small dose of one, small dose of the other, and keep, you know, titrating them up. So, comment.
Yes. So, concerning the patient we are having right now, obviously we have to treat precapillary type of pulmonary hypertension. So, we can start with vasodilators. Maybe.
So, you will choose which drugs?
Yeah. That is inhaled prostacyclin.
That's not available.
Okay. Besides that, dual therapy is always there.
No, we have dual therapy is like we have sildenafil, tadalafil, we have mesitant, ambrisentan,
Yes,
all those. So
ambrisentan.
which one to start with?
Ambris-
Randeep?
Tadalafil and ambrisentan.
Huh? Tadalafil and ambrisentan, because it comes in a combination, right? I think somebody must be very happy here, Cipla group. Very happy here. Job is done.
Yeah, and that combination showed that it worked in the ambition
It
trial.
works, absolutely, it works. Only thing is there is a problem with ambrisentan. What is that, Sujit? If you have ILD, please don't use it.
So, but this is not a patient. Yeah. So that I'm not sure in this patient that you showed whether there's a contraindication, but there have been negative trials with ambrisentan, increased
Not
mortality.
significant ILD, this was actually.
Yeah. So I think I would still go with the combo here. I don't think I would see a
Combo
major.
therapy. So I will ask him actually when to add the third drug and which third drug? Selexipag?
So, so there's if you go by the guidelines and what I do in clinical practice, so I would probably keep a good doses of sildenafil or tadalafil, not 10 milligrams of tadalafil. The maximum dose of tadalafil is
40.
excellent. So good.
40.
So good doses of tadalafil, good doses of mesitant and ambrisentan. Reevaluate. Give the patient 6 to 8.
How much of you can go
So
to?
maximum
20 or
is
30?
No. So there is no. At least the trials have not shown any benefit beyond 10 milligrams.
Oh, I have seen so many getting 20.
Yes, we see all of that, but the trials have not shown.
Okay.
Similarly for sildenafil, the
So
maximum
that
dose.
means that's the time to add the third drug.
Correct. So after 4 to 6 weeks, reevaluate do the risk prognostication. In addition to this, at baseline, you need to have a
Risk
reveal
prognostication.
score or a ESC score. See what their risk score is after 4 to 6 weeks. Put them on therapy. See what their risk score is. You don't necessarily need to repeat a right heart catheterization using non-invasive parameters.
Correct.
Get your repeat score. If they are not low risk, you have to add the third agent. Now the third agent, if you are adding selexipag, you can just add it on as a third drug. If you are adding riociguat, then remember you cannot give riociguat with your PDE5 inhibitor, so you have to stop the PDE5 and add that.
So I think this is a very clear message. Cannot combine riociguat with PDE5 inhibitors. So if the patient is on tadalafil or sildenafil, you cannot add riociguat. So your only choice left will be selexipag at the moment.
And it's very common that I see this in
Yes,
practice.
these wrong combinations are very commonly written because people have no idea that these are same group drugs. They cannot be added together.
Also, Deepak, we have cardiologists who prefer to use sildenafil because you can titrate more upwards.
Yes.
I don't know what
I was
Tala's
coming
views
to
on-
that rather than tadalafil, if there are chicken-hearted people, they can actually go on a sildenafil slowly, because that's what the sildenafil trials were actually. They were giving 25 milligram, half a tablet twice a day, and then making it up very high actually, going up to 150.
150 and even 240.
Yeah,
even.
correct.
So I don't know Tala's views on that.
So that's the super trial that you're referring to. So super trial did show that there was no meaningful improvement in PA pressures, but the patients did better in terms of their 6-minute walk distance and their functional class. So based on that, we derive some clinical benefit from that. Initially, in clinical practice, I do initiate with sildenafil, titrate up to a meaningful dose, at least say 20 BD or 20 TDS, and then would go up to and then would switch over to tadalafil. It's just more convenient.
That's another take-home message, actually. If you start with sildenafil and a mesitant, then you will be able to upgrade sildenafil slowly to a bigger dose, and then later on add to the third drug, because you can go to a supra-high dosages even in that drug. So thank you very much for everyone.